This conference will now be recorded.
Okay, Terry, we're ready. Don't forget to unmute your line.
Thanks, Nicole. Welcome, everyone. We're in the section of our series where we're looking at processes and operations. This is part of the Framing Rural Health Value webinar series. And as you know from participation in the other sessions, we've been focusing on certain elements of the Baldrige framework as a way to kind of organize our approach to sustainable hospital performance that's going to not only allow them to survive, but to have sustainable financial quality and now population health outcomes in that regard. Just a couple of updates about Baldrige itself. I think I might have explained on a previous call that we are working with the national Baldrige organizations at both the national level and the state level to kind of adapt Baldrige's awards and even their frameworks and support systems so that they'll be relevant for our state flex programs, and also will provide support to our critical access hospitals. A number of you have participated on an advisory group that Dave Dietz put together a while back, and we anticipate coming out with something relatively in the short term, hopefully by the end of the summer, so that those resources can supplement the ones that you're getting from the QIO, from other areas as well. And also that it may be a framework that will help your hospitals kind of move forward as these profound changes are taking place, and as we try to figure out how we as state flex programs can best support them as well. So today's conversation, as I mentioned, is really going to look at processes and operations. And the learning objectives, as stated here, is to discover the impact of critical access hospital for value-based reimbursement. It's an internal processes. So we're looking both now and anticipating what's going to be needed in the future. We're going to learn activities state flex program can provide to develop efficient business processes, kind of understand the value of continuous improvement of operations, the quality and patient safety processes, get a little bit into the financial processes as well, which are extremely important here. Look at how lean and other sorts of concepts will help us improve those processes or help the hospitals improve it. And then we'll talk at least a little bit about how we're going to maximize information technology to improve efficiency and quality. So those are the objectives. And here's our shaky bridge again. So imagine our hospitals are, they're currently in a cost-based reimbursement system. We have absolutely no direct indication that those hospitals are going to lose cost base, but there's a number of us who are concerned that whether or not they lose the cost-based reimbursement, that they be prepared for this value-based future and not be some sort of an outlier, et cetera. We're seeing a number of critical access hospitals moving into ACO arrangements, hospitals in Illinois, Indiana, California, et cetera, and even in the Medicaid program in Oregon now, we have an ACO-like arrangement that all hospitals are going to be required to participate in for Medicaid payment as well. So part of the challenge is to cross the shaky bridge without falling into the rapids and the stream below. There's the framework again, leadership, strategic planning, workforce, community and customers and population health processes. And so you know where we are right now, which is on the process side. Here's where the quality improvement, financial improvement, and electronic health records really lie. Electronic health records are designed to improve processes and make allow clinicians to have access to information they wouldn't have had before, to take our current processes and electronify them and at its best hardwire quality excellence. I think the same thing can be said about finances and certainly, quality, finances, and other operational processes are all kind of at play here, and we're going to talk a bit about what the strategies might be, what are the most important things these critical access hospitals might do to improve their performance, not only now under this cost-based reimbursement system, but in this anticipated future where we know the industry is definitely going and critical access hospitals are going to have to carve out a role as well. Now, let me introduce our panel. First, we're going to have a profile of a hospital in Moab, Utah. And this is a particularly good example of how a hospital that was in just very recently in a very negative financial situation, and Rob and Craig will talk about it just a little bit more, were able to alter their processes and in a very short period of time kind of turn around their financial fortunes and become much more positive. Brock Slaba is also here as well, and Brock and I have known each other for years. He's from he's the Senior Vice President of the National Rural Health Association. You folks all know him, I believe. And Brock is not only a former critical access hospital administrator, but he, as I indicated, he now is very directly involved in policy matters affecting rural hospitals. And it's really great to have this sort of a panel. Rob and I worked together years and years, gosh, it's been probably more than 20 years ago. And it's really good to have both he as CEO of Moab Regional Hospital and Craig Daniels, their CFO, to kind of lead off and talk about their experience and how they turned around the circumstances at this hospital. So Rob or Craig, I'm not quite sure which one of you wants to go first. And they're going to talk for about 20 minutes. I've asked them to not go much beyond that so that we're going to have some time to have a panel discussion about some key areas of potential process improvement. And then if you have questions, you can either ask them by hitting *2, or you can type them into the chat box, and Nicole's going to be watching to make sure they get asked. Rob, am I introducing you first, or do you and Craig want to?
You are, Terry.
Okay.
Okay, I hope everyone can hear us. I want to thank you, Terry. And I also want to thank all the participants today of the FLEX program, the National Health Resource Center, for hosting us today. And I will be the first to admit that I am not an expert in financial turnaround. It was simply that we had to work through these issues and really weren't given much of a choice. It's either that or close the doors. And Craig here was the one who had his boots on the ground and came up with the majority of the plans. So he will get into the details a little bit later. I will start off by talking a little bit about the Moab Regional Hospital. It's a brand new facility. We are a critical access hospital in rural Utah. We're about 110 miles from the largest tertiary center, which is in Grand Junction, Colorado. And we're approximately 3.5 hours from Metro Salt Lake City up to the north. We have 17 inpatient beds. Over 3/4 of our revenue comes from outpatient services, which shouldn't be too surprising to most hospitals. Our service area population is around 12,500 individuals, which does not include the in excess of 2.5 million visitors who come through Moab yearly, 2 million of them coming to Arches and Canyonlands. But if you've ever heard of Moab, we're fairly well known for our mountain biking and Jeep capital of the world. We have Jeep Safari in April, and so we have a lot of outdoor activities here. We have roughly 160 employees here. As I had mentioned, we built a new hospital in February of 2011, which is when we moved in. To do that, we borrowed approximately $32 million from HUD to get into that wonderful new facility that I showed you at the beginning. We have a board of directors of 7 members, 1 physician member, and we are a 501c3 private nonprofit facility, one of, I think, 9 in Utah that are independent rural facilities in Utah. I'm trying to move us along here. We have an active medical staff of right now 5 family practice physicians, 3 who do OB C-sections, 2 who do not. We have a general surgeon, 2 orthopedic surgeons, 1 anesthesiologist plus 2 CRNAs. We have 4 emergency room physicians who cover the ER 24/7. And we have 1 plastic surgeon along with various visiting physicians such as cardiologists, neurologists, ophthalmologists, oncology, coming over anywhere from twice a month to once a month. May of 2012, the fireworks started. We had some financial concerns prior to May of 2012. But if you want to talk about a shaky bridge, we hit our shaky bridge and got a little wet from that at that point in time, because we had the choice at that point of either making payroll to our employees or defaulting on our monthly HUD loan payment. And from all indications we made the right choice in that we made the choice to pay our employees and then deal with the consequences of dealing with HUD later, and which is what happened. And we did a lot of turnaround planning, and as Craig would say, a real call to action, and we listed a few of the salient points that could be addressed in any turnaround plan, and we addressed many of, if not all of those. Some of the critical strategies, we're certainly looking overall at revenue cycle, payer contracts, removal of waste, inefficiencies. All of those, while not listed here, are part of a turnaround plan. Then we got into some real specifics, and I'll let Craig address most of these. This is what staff did, and the first thing they did within 7 days of notifying HUD was coming up with a 16-point action plan. We then also got very involved with the board. The board chair became intricately involved in the efforts, and in all honesty, the board went from virtually minimal involvement to total involvement in probably 2 to 3 weeks. 0 to 60 very quickly. And so they got very involved. It was very multifaceted. We were very communicative with staff, the community, employees, physicians. We were very transparent in just about everything we did. So while we're not going to hit on every point here, I'll let Craig start hitting some of the action items that were critical to our turnaround. So Craig?
Sure. I'm Craig Daniels. I'm the CFO. I came in that glorious month where the fireworks hit. My first day on the job, I had $2,000 in the bank and was faced with a $300,000 payroll and a $270,000 mortgage. And so anyway, we had to take off fast. We started peeling back the onion and turned over every rock, and we had to create an immediate vision of our situation, so that not a panic kind of thing, but we had to we had to let people know exactly where we were. We had to be honest what had happened and what had happened over time. The largest thing that we did is we engaged fresh eyes. One of the things that the previous CEO did, he reached out immediately when the CFO walked off the job, I guess, on January 2nd in 2012. And he reached out to Greg Rosenwald. Greg immediately brought in an interim CFO and started, again, peeling back the onion, finding out where they were. Their financial statements were not accurate. They just had to figure out exactly where they were to go forward. We hired a consultant. We contacted our accounting firm and asked who they knew could bring somebody in. They actually brought in a person that did our pro forma for our bonds. Tried to compare why we were not making the payments that were on the pro forma. And HUD mandated that, and the bank mandated we bring in a management company. And so we sort of had two CFOs and sort of two CEOs for a while, which was interesting. But it put more people and more horsepower to it. The other thing that we were hungry to look for was benchmarks, exactly where we had been, where we were, and where we needed to be, and tried to educate the staff that they didn't have to live like they had for the last 30 or 40 years. We reduced expenses. We looked at made some hard decisions that did not go over real well, especially with staff. We hit their pocketbook in their retirement, and then we reduced a few staff in a few departments. We bought out some rental contracts. We had rented equipment and paid for it 3 or 4 times. And when I looked at what the purchase price was and what we'd paid in payments, nobody had jumped at the opportunity to buy it. Even though we didn't have the money, we made the commitment to do it. We were severely behind on our 990s. The IRS penalized us for not doing such. We had to hire an accounting firm and an attorney to help get the 990s done and the penalties abated. Anyway, we just continued to look at everything. A lot of things had not been reviewed for either write-off or payment. And so we started putting more eyes on every transaction we had. When it came to accounts receivable, we had to try to figure out why we didn't have any money in the bank. It was taking us up to 6 weeks to get a bill out the door. It had actually been a community problem. People in the community, I asked them first day, I said, what's the biggest thing that could help the hospital, or I could help the hospital? And they said, get the bills out the door. And I was, wow, they know it. And so I came back and we told people we're going to drop a bill in 4 days. We're not going to drop it in 6 weeks. We're going to create a vision of 4 days. And so the staff met in rooms and went through the complete process of all the charges and how they flowed, how the bills were reviewed, how they were coded, and then how they were dropped. And we got to the 4 days. It took a little while, but everybody knew the 4-day vision. We started asking for dollars. We hadn't when we had to figure out how to ask for dollars and teach the staff to ask for deductibles and copay and how to be educated about how to calculate. So we had to get some eligibility software. We had a pre-authorization person. We'd been writing off MRIs and surgeries and not getting surgeries pre-authorized or high dollar incidents. And we did that rather than expecting the physicians to do that. We had to go for some governmental assistance. When they moved in the new facility, they lost their DISH dollars. Medicaid rural DISH is allocated to hospitals that are in a government facility. And the old building was a county-owned building, and this building was owned by the 501c3. And so immediately they were cut off from Medicaid DISH. The Hospital Association, Greg Roosevelt, again, our flex coordinator, Senator Hatch, and Medicare had to be involved, CMS had to be involved to change the state plan. And that all transacted over a matter of probably about 8 months. But that meant about $90,000 a month that we'd been cut off from, and toward a $270,000 mortgage. That's significant right there. And the one caveat when we did get put back in the DISH program is we were not able to pay our seating dollars for the DISH. And so we had to go to the county and the city because it has to come from government dollars. And the county put up $100 and something thousand, $140,000 I believe, and the city put up $85,000 toward our DISH seating and put it in with our healthcare special service district. The other thing we tried to do, and this was unsuccessful, but we put time into it, was try to restructure our debt. Our payments on the average are right around 6%. They were a little bit desperate when they built this hospital. The old hospital was probably just about ready to be closed.
50 plus years.
Yeah, graphically, it had sewage in the basement, and people were working in that. They had outgrown their facility, and it was a hazard. And so the state just said, you've got to build a new facility, and so they probably didn't get the best interest rates. They probably didn't get the best bank partner. But they did get a loan, and they did build a building, and it was just how they were going to pay for it was the big issue. What we found is that our loan has a 17-year lock, and we cannot refinance the loan. It's a 25-year loan. We could not refinance it, and so we're just going to have to live with our current rates and our current bonds. The other thing when it came to making sure we're not leaving money on the table, we tried to optimize our reimbursement and our third-party contracting. We had extra eyes come in, and we filed a 2011 cost report in the first few days I was here. It probably was not the most perfect cost report. The audit hadn't been completed. Several things had been completed, but we had to file the cost report in lieu of Medicare cutting us off from receiving payments. And so we filed a cost report, had somebody else come in and look at it. We revised that cost report and amended it. So again, it doesn't hurt to have outside eyes look at what's going on. We started preparing interim cost reports. They had moved into a building, and they were still living on critical access dollars from the old building, which didn't have any depreciation or interest expense. And so by doing the interim cost reports, we were able to get some lump sums from the government, from Medicare, get our rates adjusted so that we had more money coming in. We had a 2010 cost report audit. They wanted money back. We scrutinized those audit adjustments, and actually they gave us a few $1,000s rather than us owing a lot. We had extra eyes look at the capitalization of the hospital building. That's assigning the lives to the concrete, to the roof. We componentized it, and we were able to reduce the average life of the project by 4 years, which increased our critical access payments. We also did something that I'd done in other Utah hospitals. The state of Utah will fund 50% of a state Medicaid worker, and to be on site in the hospital. If you look at the state website, it says go to your local hospital and there'll be a Medicaid worker. We didn't have one. We worked with the state, put one in, and actually this year, because of the ACA, I believe the state is paying more than 60% of our costs. We got a reduction. Again, the government's wanting to make sure that these state workers are in their hospitals. That decreased our bad debt, increased our Medicaid payments, and another thing that we found out is we could go into the upper payment limit program for hospitals in Utah. And so not only did we get our dish back, but we got upper payment limit monies. It was almost equivalent to our dish dollars, so it was another $90,000 a month that helped us. We renegotiated our rates with our payers, grossly getting underpaid from them. On our pricing, before I came, we have a state data bank that compares by DRG and outpatient surgeries, ER visits, those kind of things. And I could see that the hospital was a good third under pricing. So we hired an outside consultant. They looked at MedPAR data, some cost report data, so that we could expand it, look at room rates, our supplies, those kind of things. MedPAR does not have that, so you have to look at cost reports. The previous CFO had always compared against critical access hospitals. Our outside consultant said, if you want to lose money, compare yourself to critical access hospitals. And so we started looking at non-critical access hospitals. We're a resort community, so we looked at resort hospitals in Utah. We looked at a fierce competitor on the Wasatch Front, Intermountain Healthcare hospitals that keep their prices low. We looked at some Colorado close hospitals, and it turned out that we were 44% below market on our rates. And every payer in Utah pays a percent of charges, and so there was an automatic amount of money that came in the door when we increased our rates. Now I'm going to turn it back to Rob.
Okay, real quickly here, I do want to mention the generosity and helpfulness of our Flex program assistants. Craig already mentioned that Greg, who was the Flex coordinator for the state of Utah, he also works for the Utah Hospital Association, helped with the CFO recruitment and got it started, which was real key. They offered resources. They paid for our community needs assessment to be done last year. And Greg, and also Dr. Don Woods and his staff up in Salt Lake State Department have been very helpful in assisting Moab Regional Hospital. These are some of the financial indicators showing you the historical significance. Again, this information came from the National Rural Health Resource Center and the Technical Assistance and Services Center. Just pointing out the fact that our net days in AR went from 103 down to 50, cut that in half. Note that our days cash on hand went from, well, maybe 2 hours or 29 days at least in 2011 to 144 and higher already this year. And our operating margin went from a negative to a positive 6% last year. So the end result was today, while we're not all jumping for joy and jumping in the warm air, we are off of the HUD priority watch list. It was pretty unique for HUD themselves because hospitals either get sold or close. Not many get taken off the priority watch list, so they are exploring how this actually happens, but we won't have our monthly HUD phone calls. We'll still have to submit data to them, but for the most part, if I had to summarize it, I would say it's leadership at an organization that'll get you through these times. It's aligning your goals with what is appropriate. Quality care and process improvement, as Terry alluded to it in his opening statements, are just so critical here. I'm of the firm belief that if you provide quality care, the financials will follow. And so we implemented all of that, as you can see from what Craig says, and just improving our processes made a dramatic improvement here at Moab. So that's our story. Craig, any last words?
That's it.
Okay. Thank you all, and look forward to the panel discussion next.
Yeah, and first of all, I want to congratulate you in that turnaround. It's not unique. We have seen similar turnarounds, particularly when you bring in outstanding new leadership, as I think, I mean, that's remarkable just in terms of that turnaround. Let me ask you guys, reducing your days in accounts receivable from 103 to around 50, approximately how much extra money would that be bringing in? It's substantial, isn't it?
Yeah, it would brought in the 1.2 million right automatically. I remember right when I calculated what it would bring in, and 1.2 million in the bank was tremendous. This hospital actually had a hard time paying its bills for years. And when I told people that they could have money in the bank and they could pay their bills, they were just amazed that could happen. The other thing, and I probably didn't touch on it, but back to the processes, a third of our bills went out and got denied and came back for inadequate or incorrect information. And so we had to bring our error rate down. That also closed a huge gap, not only getting the bill out, but getting the bill out correctly. So.
And this is one of those situations. We have, I don't know if you guys know it, but in some of our state flex programs, there's actually assistance available to the financially troubled hospitals, and many of them, refuse to take it, and there's probably a variety of reasons why that happened. But another really crucial point, I think Rob mentioned it, is the leadership is required for this kind of a turnaround. And again, we've been working in the Mississippi Delta with some of the very poorest hospitals in the country, and we see stories like this frequently. So much of it comes back to the leadership and the process improvement. There seems to be so many things that was going wrong previously that by tightening up those processes, kind of increasing your financial this was highly financial, but I would strongly believe that your quality processes improved, et cetera. So it's really a testament, from my observation, to process improvement. I'm going to turn things over now, or I'm going to have a conversation, and I want to invite both Rob and Craig to weigh in here as well. But Brock Slabaugh and I talked about, what are the most important things that we can convey to the Flex program people, and we kind of arrived at Brock's been giving various presentations, and I think he concludes with about 6 different things that hospitals could do. And one of them is just simply, because we're going across that shaky bridge, is optimizing fee for service. So Brock, why don't you talk a little bit about revenue cycle management in particular? We've already seen it's well over $1 million difference to take a hospital in over 100 days AR and bring that down to something like 50, which is right around or maybe a little below the industry average for critical access hospitals. Brock?
Well, thank you. Yeah, I think I'm, can you hear me, Terry?
Yeah, I can, yeah.
Okay, great. Well, thank you, and thanks for the invitation to participate in this webinar. I've been particularly inspired about the word from Moab, Utah, and the great work that they're doing in terms of illustrating, I think, firsthand some of the precepts that I'll be talking about here, Terry and I'll be talking about here for the next several minutes. It's also good to have so many friends that I noticed on the left side of my screen on the line, so I thank you for the opportunity. Optimizing fee-for-service, this is the current environment that we're in. I guess this is the left side of the shaky bridge, if you want to look at it going from left to right. We still are operating in this environment, and so we need to be very particular about paying attention, sticking to the knitting, as it were, on some very basic things, and that's revenue cycle management. We saw a tremendous illustration about what the impact that has on a facility and its operation. I believe in the era of the Affordable Care Act, as we continue to implement that program, this is going to be a core competency of all healthcare providers. And so doing what you can as flex coordinators within the states to get attention paid to this and to understand the impact it has on their facilities cannot be overestimated. Related to payer revenue cycle, of course, or a subset of that would be payer contracts. And just alerting you to the Affordable Care Act and the development on the exchanges of narrow networks, also called skinny networks, that will be, I think, producing stress on rural facilities particularly, as it'll do 2 things. One, it could decrease payments from insurance providers to your hospitals. And then secondly, it is going to possibly shift costs or more costs to the client or to the patient. And so your facilities are going to have to be much better at collection on co-insurances and deductibles that will surely be increasing as the implementation of various features of the ACA goes into effect. And then finally, market share. Again, this is basic, but it's trying to do what you can to retain, understand where your market is seeking services, and why it is that they're leaving your community to go to other places for services. And that's just a critical factor in this development of your business. I saw in Tennessee the Blue Cross and Blue Shield there did a study and concluded that a majority of care is leaving rural communities and going to urban and other areas for services that could have been easily provided in the local hospital. And they call this, it's silent but deadly, because these hospitals could have been benefiting from that market share staying local. So, hey, Terry, I'll turn it back over to you.
Yeah, let me just jump in on that. That's one of the pieces that I personally have a real challenge trying to communicate to rural hospitals in that regard. And I don't know if the rest of the folks on the call have been the same sort of thing. But, I noted that in the Moab hospital, 77% of the revenue is outpatient. So these folks are not making big money on their obviously their cost-based reimbursement basis. They're making their money on the outpatient side. When the outpatient revenue leaves, as Brock has indicated, and I really refer to that Tennessee study as well, that is absolutely important because, in essence, there's only a number of ways that critical access hospitals, given the kind of challenges that they're facing, are going to be able to be financially successful. And one of them, I strongly believe, is we've got to stop that out migration for care that could be provided locally. We've got to inspire the confidence of the local community, and in my opinion at least, the community engagement activities we can be doing and helping our hospitals engage in will have a financial impact. They are going to be important, and it's just something that, marketing, we also have a number of examples now. I've really been trying to track marketing success and, kind of models where the hospital has kind of turned around the public perception, has cut in dramatically into that out-migration for care. And by expanding that outpatient revenue source of funding, I mean, that becomes the model for success, I think, both on this model, but also into the future as well. Hey, Brock, but before we move on to the next one, could you just briefly talk about a skinny network? Because I've heard this. I have a good idea what it is, but could you explain how you interpret it?
Sure, Terry. Basically, one of the motivations in this new environment for market-based healthcare, insurance companies will be competing for business of customers, of patients, basically, on price or premium. And so the lowest priced premium in the market could attract more insurance clients. So the way that these insurance companies will produce lower premiums is they can only do it in a couple of ways. And one important way is to reduce payments to providers. So they will be putting out, say, bids, if you will, almost, for providers to say, I have 1,000 lives that I'm going to be paying for care for, and I want to have services provided at the least cost, and they will award business to the providers that can in return for higher volumes, provide lower prices to the insurance company. And so this limits choices sometimes for the insured, for the customer, because now instead of a panel of anybody they want to go to, they may have a panel of fewer providers, but yet the return that they get in terms of benefit is a lower premium cost and perhaps cost sharing for the individual patient when they go and seek care. So so in this process, rural providers could be particularly hurt because, first of all, they're not in the mainstream of negotiating contracts with these exchange products. And number two, in order to do contracting efficiency, some of these insurance companies may even choose not to engage in terms of contracts with individuals outside of, say, some of the urban areas. So that's kind of the precept of this. I'll stop there to see if there's any questions, Terry. I hope I wasn't too confusing.
No, it's a concept that is going to narrow the patient's choice, and it needs to be watched pretty carefully. But we'll pass on some additional information on that at a later time. But you're going to start hearing this term, because I've heard it a number of times now, and kind of moving forward here. The other piece is really, and I think we saw that in the Moab example, is driving out inefficiency. It's one of the fundamental strategies for hospitals kind of crossing the shaky bridge into the future. So you want to say a few things about that, Brock?
Yeah, I'll just be very quick with this, Terry. The Moab experience, I think, is extremely useful here because eliminate waste using lean techniques. We've seen those processes. I think state flex programs could be very helpful in this and in reducing variation through Six Sigma techniques. I put flatten the organization in. I realize that many of our rural hospitals are a mile wide and an inch deep in terms of management. So I think that they're probably as flat as they can get, but it's never inappropriate, I think, to take a look at that one more time. And then the last one here is really reviewing bricks and mortar budget, and I sometimes put that into quotations, so the bricks and mortar budget, because as we move into this new environment, hospitals of the future, in the future, will not be necessarily a place, but it will be a concept. It will be an organizing principle for healthcare within a population. And so as you look forward to services in a community as they're organized, bricks and mortar may not be as important going forward as they might have been, say, at some time in the past. Now, that doesn't say that you shouldn't make them attractive and improve them significantly in order to be competitive, but it just causes one to kind of pause a little bit and look at your budgets and see what might be more appropriate in terms of budget, say a telemedicine system or some kind of strategy to move into population health versus investing maybe capital in bricks and mortar. So those are kinds of the considerations there on looking at inefficiencies.
And Brock, I have a concern about overbuilding as well. And in essence, from a conversation with Rob, it might have been that $32 million was too much to borrow for that hospital. It might have been. I mean, they've got 17 beds, et cetera. And I don't know if Rob wants to weigh in on this or not. But in essence, we are seeing a number, even HUD loans or USDA loans, that may be excessive. Just because they'll loan you the money doesn't necessarily mean that it's a good idea to take it in that regard. And probably in hindsight, even though Rob wasn't involved in the loan and getting the loan itself, it might have been wiser, for a variety of the reasons that you've already said, to build a facility that was less expensive and would have been less debt to pay off down the road.
And Terry, I do agree with that. Our pro forma, I guess, when we look back at it, showed about $24 million to the maximum we should borrow, and for whatever reasons, it kept going more. And maybe it was anybody can borrow money. It's just whether anybody can pay it back. So that was Craig shaking his head. When you have $3 million a year in debt payments, it creates issues elsewhere.
It is an issue, and I don't want to be too critical here, but we've tried to get the point across. In many cases, the folks that are calculating this, I know of a hospital where, I'm not going to mention which one it is, but I daily actually reviewed the amount to be borrowed and said it was way excessive, and they ended up giving them the HUD loan anyway. So now that hospital is pretty much on the verge of closure, and it's just, we need to be smart about those sorts of things. And again, a number of the hospitals that were kind of grandly designed, particularly some of our smaller rural hospitals, are really suffering financial problems. The next area has to do with engaging the medical staff, and we could have expanded that to engaging the entire staff. But Brock, why don't you say a few words about why you think this is so important?
Well, I think that the medical staff is the engine that really, I think, drives the essence of these rural facilities. And I can say that if a hospital is having financial troubles in a rural community, the first thing that you look at, of course, is their professional staff, both doctors, mid-level nurses, physician assistants, et cetera. to see how you can affect that market share I talked about in the first slide. But basically, the medical staff should be involved at every level and function of the organization. That includes strategic planning, governance. If they're not involved in your governance structure, it would seem to be very appropriate to have them in that capacity. Operations and evaluation. Another thing that I've seen, and I was guilty of this when I was a hospital administrator working at a rural hospital, is investing in physician leaders, getting them to conferences and meetings where some of these concepts will be discussed so that they can begin to engage on how they can contribute to a successful operation. And then the holy grail is really developing salary systems based on based on productivity, customer service, and other factors that would really be helpful to knowing their value to the system locally. And I think that there's been a lot of progress made, I think, in a lot of facilities, but anytime I hear a lot of people talking about losing money on physicians in terms of having to employ them and other such things with that. I think moving into these reimbursement systems that recognize things other than just productivity is an extremely important element to making sure that this happens. So medical staff is an incredibly important feature here.
I totally agree with you on that. And again, even though there are some pieces of the Affordable Care Act that help to, perhaps increase the supply of primary care physicians, we're currently stymied by the lack of residency programs for primary care docs and the lack of spaces, et cetera. So they're going to be key. I totally agree. And we're talking partnerships as much as anything else. The next section is really preparing for value-based models. As I'm getting deeper and deeper into things like medical homes, care coordinations, accountable care organizations, et cetera, it's striking me that the processes in those configurations are way more complex than either fee-for-service or cost-based reimbursement. So we're going to have to really be careful on this side of it. Brock, you want to make some other comments on that?
Sure. Very quickly on this one. This is the right side of the shaky bridge if you're looking at it from left to right. So how do we move into this population paradigm of healthcare? And these are some of the examples, I think, on this list of how you move into that. One recommendation is the patient-centered medical home. That begins to implement, I think, a system, if you will, for a population-based or beginning a population-based approach to healthcare. And I think that that could be an attention that could be given by state flex programs on how you move physicians and clinics, mid-level physician assistants and nurse practitioners into this medical home model. Care coordination is a kind of a subset of patient-centered medical homes, but it's an integral part to this management of care across the continuum so that there's not any loss of information, and certainly there's no duplication of services provided in each of the locations of care. That's incredibly important. And of course, ACOs, accountable care organizations, these are phenomenon that are largely in more urban areas, but they are encroaching into rural areas, and we have some examples of those actually through various models being applied in rural communities. So we'll be anxious to see the results of those. And then, of course, looking at prevention and wellness, and then using the EHR, the electronic health record, as the conduit to make a lot of these population-based models work.
Right. And the only comment I'd make on that last point is that it's going to be a bigger job than just collecting the information. We're going to need to analyze the information, and we are very short of data analysts in rural areas. So it's one of those things that is going to have to be factored in. It isn't just getting the information. It's basically using it effectively to improve care and that's going to require, data analysis and some skill sets that we're going to have to build in our rural communities or in our, accountable care organizations or networks or whatever. But it's going to be a challenge. Engage the community. We've talked a good bit about that as well, but it truly is about instituting processes so that we are kind of engaging the community on a regular basis, not just once every 3 years as a requirement, but we're starting to move out, and in our processes, we're including others and including long-term care providers, mental health providers, employers, schools, et cetera. And I think, as we had suggested in a previous presentation, we don't have to do all of those things now, but for critical access hospitals, and I think for flex programs, I think we need to be identifying what are some simple things that we might do to engage the community, and as a bonus, persuade them to stay locally and such. Brock, any other comments on that?
I'll just simply add to what you said, that the hospital can't and shouldn't do it alone in the future. So the hospital in a rural community is part of a system of healthcare that should be developing, looking for partnership, looking for leverage that you can provide to your services with other providers in the community, and I think you listed a good set of those, and try to do the best you can at making healthcare accessible across a wide area of providers in a rural community.
And then I think the last one we have really has to deal with documenting and promoting hospital value. One of the reasons that people leave the local, there's a couple major reasons, as you folks probably know. One of them that is generally a surprise at the hospitals is that the people in the community don't really know what services are available. They're not going to be thinking about cardiac rehab until they need it. In many cases, they may not even know that it's in the rural hospital. In fact, over and over again, as we've done community assessments, we discover that most of the people in any community are really unaware of the scope of services in the local hospital. But the second one really has to do with confidence in that local hospital. And it's my belief that we don't do enough as smaller rural hospitals to promote the quality of care that we have. And to me, it's got to be evidence-based in that regard as well. And Brock, why don't you talk a little bit more about that one?
Yeah, I think that transparency is going to be ever increasing in this environment, and so when you look at things as simple as charge masters and trying to deal with the public on a multitude of issues, there's going to be more information that your public's going to have about you, and being able to understand what that is and deal with it appropriately. I agree completely, too, about the marketing. I think one of the saddest things to me when I would go around to my community when I was a hospital administrator and talk about some of the services that we had, and someone would raise their hand and said, well, I didn't know you had a CT scanner, or I didn't know you had digital mammography, or anything like that. And so I think there's never enough that we can do, I think, to make sure that your community understands the array of services that you have to offer.
You know, it's interesting. I've had some conversations recently with some of the existing accountable care organizations. You know, they're almost all urban-based. We're starting to see rural ones popping up, and but in essence, you know, we've been trying to learn kind of what are the urban-based accountable care organizations learning, and what kind of implications does that have for rural hospitals. So 2 weeks ago, I had lunch with the director of the Accountable Care Organization for the Essentia Healthcare System, which has rural hospitals in 4 or 5 states. And I asked her about how, you know, in the past, that there was always the incentive to either own or manage or have a strong relationship with a critical access hospital because it was going to mean referrals. And actually, under the Accountable Care Act and the ACO reimbursement system, in essence, those referrals are no longer going to be wanted in most cases. In other words, if they become cost centers, the surgery that's done in the bigger hospitals are going to cost these bigger hospitals under this, the reimbursement model that the ACOs are using. And then I asked her, well, what would it be? So she's saying, if the hospital can't show value to us, if they haven't documented value, we're simply not going to be interested in working with them. And she said, we would be looking for what are their quality scores, what are their HCAP scores, how are they going to be able to provide value for this larger kind of ACO model or a Medicaid. That this particular ACO is entirely capitated and risk-oriented in terms of their Medicaid, all their Medicaid patients as well. So I think one of the reasons, and it's the last one I've listed here, participate in value models, is that if we're not able to document our outcomes, put in a plug for MB-QIP and our financial numbers, et cetera, we just may find ourselves as critical access hospitals outside of these emerging systems. And we may not need to be in them now, but at least as we predict the future, we're going to have to find some sort of a place. And I think so much of it is going to be based on the documentation of value. I want to thank, I've got two more slides, and you folks have probably seen it, is that we don't have to do all this stuff at once. The Moab Hospital actually did. So their journey of 1,000 miles began with a lot of steps here. But for critical access hospitals, particularly on the road into the future, across that shaky bridge, it's kind of one step at a time. Be very careful about rushing into anything at this particular point. But as the next slide indicates, even if you're on the right track, you'll get run over if you just sit there. And kind of what I think we've seen in this past hour has been a real indication that a hospital in absolutely desperate circumstances can turn itself around with the right leadership and with the improvement of their financial processes, their quality processes, et cetera. And I also think we've looked at some of the basic issues that kind of out there right now that, I would agree with. These were really more Brock's, top 6 things to be looking at right now as critical access hospitals, but I agree with them all. And I think, if we can focus in on that revenue cycle management and improving our financial processes now, our quality processes, et cetera, and prepare for the future, then the Medicare Flex programs are anything they can do in that regard is going to be important. And I think, I will express my optimism that those that can survive this interim period